ready. So we do have a few prepared to talk about. So we'll go ahead and I'll introduce myself and then Rachel can introduce herself. So I'm Elise Spronk and I'm an occupational therapist at Kinetic Physical Therapy. I've been here for about 19 years, working with children and adults for a wide variety of different reasons. So love what I do, love my team, and the people I get to work with. So I'll let Rachel introduce herself.
Yeah, so my name's Rachael Barnette. I'm also an occupational therapist. So I have been working here for about 3.5 years. And prior to that, I was a student here. I work in our Ames location and primarily see pediatrics. So I see a variety of pediatric patients, but particularly have an interest in pediatric mental health and trauma, and more like executive functioning. But like I said, I see quite a range of pediatric patients and different concerns. So yeah, well, we can jump in a little bit more broadly. We get the question a lot about just like generally speaking, what is OT? What do you do? What do you treat? And that question's kind of hard to answer because depending on the setting, OT is very different and very broad. So if you asked an OT that worked in a hospital setting or in a nursing home versus in an outpatient setting like where we work, they're going to give you a very different answer. But specifically at Kinetic Edge, we work with, like I said, pediatric patients, addressing skills like play and learning, sleep, self-help skills like dressing, feeding, just more of those like developmental type skills, as well as emotional regulation and attention, more of those skills that play into learning, as well as our OTC, more orthopedic conditions as well. So treating hand, wrist, elbow concerns, arthritis, pain, post-surgical injuries, things like that. So really the goal of OT is just to get you back to doing either what you aren't able to do and what you need to do, or what you were previously able to do, but what you need to get back to doing. So it's very general, it's very broad. And like I said, depending on what kind of setting OT might be working in, that might change the answer you might get from an OT. But specifically at Kinetic Edge, we kind of see the pediatric population and then more of that like orthopedic upper extremity type OT as well. So we can go ahead and either read off questions that we've gotten, or if there's specific questions that people have and want us to answer, we can do that as well. You can either unmute and ask a question or type in the little chat box. It's completely up to you. But if we don't get a question, I'll go ahead and read off from our little questions here.
I have a question.
Sure, go for it.
Kind of, how do you know like when might be a good time, like say, you know, if your child's dealing with outbursts but you're not sure, like is this a normal kind of like developmental thing, outbursts, or like when would it be that you need to kind of like take the next step and reach out to you guys?
I would say, like, if you have concerns, it never hurts to reach out. One thing that we can offer and do offer are what we call screens. So it's a 20-minute time frame where you can sit and talk with an OT and just talk about the concerns that you're having. And we can kind of decide, like, is this within typical, or is this something that you might benefit from, like a plan of care, benefit from therapy? And even from there too, like, is OT what you need, or is there something else that might be more beneficial first? The other piece of that too is like talking to your pediatrician or their primary care doctor, because they're kind of a wealth of knowledge too. I would say like using your parental judgment too, of like, if something feels hard, like it just shouldn't feel like you're fighting a battle every single day. And a lot of times I feel like people wait until it's like dire straits and they wait until they're drowning to ask for help. And that doesn't need to be the case. You don't have to wait for a diagnosis to qualify for services. You don't need to wait until things are like outside of the realm of
Mhm.
being able to handle before you can ask for help. So
I sometimes call it the eggshell test. And so if you feel like you're walking on eggshells around your own child, just because like you don't know how they're going to respond to maybe even a minor question or how things are going to go if you're going to a restaurant, and you just kind of feel like you're always on a little bit of a protected mode yourself, that's probably a pretty good indication that it's maybe a little bit outside that realm of what would be considered typical. So
I have a
great.
question. Can you hear me?
sure.
Yeah.
Yep.
Okay. So I'm currently a student and trying to get my OT. And I'm planning on taking a gap year. And from what I know, I read that like by 2027, master are not available anymore. So does that mean only doctorate now?
Um, I am not sure.
Mhm.
That has been the talk for a while. So I graduated from OT school in 2021, and when I graduated, they were saying that as of 2023, I believe, that it was supposed to be like a doctoral level degree only starting in 2023, and then that was pushed back now to 2027. So it's hard to say whether that would be the case, but essentially what that means is like anyone that has a master, if you went to school and you graduate with a master's degree, you'll still be able to practice. So it doesn't mean that if you have a master's degree and you're practicing, you need to go back and get a doctorate degree. It just means anybody that's starting OT school after 2027 is going to have to enroll in a doctoral level program.
Okay, so no master anymore, just doctorate.
After
Yeah, and I guess I
2027.
yeah. And I would just check with the schools that you're interested in. I'm on an advisory board for like Allen College here in Iowa, and I know that they're going through the process of converting from master's to doctorate. And so a lot of those programs are kind of perhaps in the works of doing that, but yeah, the timeline for yeah, the timeline might be different for some of those different schools. So yeah. Any other questions from you guys? Otherwise, we'll keep going with some of the questions that we had received previously.
Okay, well, I'll read off a question here. We kind of answered the question like, how do I know when it's time to bring my kiddo to OT? But another question kind of similar to that was like, what could I bring my child into OT for, or what could OT work on or address?
Yeah, do you want me to start with
Yeah,
that
I'll
one,
let you
Rachel?
start with that one,
Okay.
Elise.
Okay, sounds good. Yeah, so Rachel had kind of previously talked about the wide range of things that occupational therapy works on. Um, I oftentimes will explain like kind of our development like a pyramid, and I think there's a lot of different things on that pyramid that we address. So if we were going to look at a child's function like a pyramid, academic learning would be way up there at the top with behavior and activities of daily living down at the bottom. And a lot of times parents maybe reach out because there's an issue with one or several of those areas. So maybe the child's having difficulty with reading or with math. Maybe they're having a difficult time following directions, making transitions from one activity to another, which is affecting their behavior, or maybe they're having difficulty with their morning routine or bedtime routine, toilet training, sleep, all of those things in that ADL category. Underneath that are all sorts of developmental skills, which should just be fairly automatic for the child. And these are some of the skills that we begin to kind of work on. And so that might be fine and gross motor coordination, bilateral coordination, or using the two sides of the body together. It might be visual skills, so like visual tracking, which can definitely impact reading or other academic skills, balance. And so there's a wide range in that middle. At the very foundation of that pyramid is our sensory processing. So how do we take in everything going on around us and respond appropriately to it? So, for example, all of us are sitting in a different environment. Rachael and I are in clinics. You guys are maybe at home, and there's different things happening around, and we're all still able to hopefully focus on what we're talking about. I've got background noise. There's people, working out in the clinic behind me, but I'm able to filter that out and still stay, in conversation with you guys. And so that's a aspect of sensory processing, right? I'm, wearing something comfortable, so I'm not distracted right now by maybe my toe going through a hole in my sock, or maybe, my pants feel too tight. And so that's part of my tactile processing. And so that's, very foundational, because if something is going on there, I'm not going to be able to do my best up at the top. Then the other aspect is that reflex integration piece. And so we're all born with reflexes and they help us develop. But if they don't get integrated, so as we develop, those reflexes kind of go on a permanent vacation. They no longer drive our system. If that doesn't happen, then that can also impact my foundation. And so really occupational therapy can work on so many different areas. And what we've discovered in our practice at Kinetic Edge is that if we start at the bottom and work our way up, it's just going to help solidify the improvements and progress that we make up at the top. So, a top-down approach for behavior might be, rewards or consequences, or a sticker chart if you follow instructions so often. Well, that's fine if the problem isn't because of something more foundational. But if the problem is not that this child just is being defiant and not following directions, but maybe they have an auditory processing problem where they can't follow a verbal instruction, or maybe they have some sensory processing that causes them to be more distracted. So in the middle of their morning routine, little brother comes running in, and now, oh, I've lost it. And so that then can become really frustrating for both the parent and the child, because we're not ever able to fill up our sticker chart. And so instead, let's, identify where that problem is. So anyway, anything to add to that, Rachael?
No,
Okay.
I think that's great. And just like to piggyback off of that too, I think so often OT kind of gets pigeonholed as like sensory processing and fine motor.
Mhm.
And I think like OT at its core started as like a mental health profession. And like it's kind of making its way back towards that. And the reflex integration side of things, like especially for kiddos who have experienced trauma, those primitive reflexes kick back on or were never integrated because those are kind of our body's natural safety net, or those are like our body's way of self-protection. So if a kiddo either one never grew up or never learned self-protection, like they just were never in an environment where they were able to like feel safe, or they were in an environment where they were able to feel safe, but then something happened that like triggered them to be unsafe, or something traumatic changed that for them. They're kind of stuck in these reflexive patterns. So then like our job is to help teach their body, like how do we get out of these patterns and how do we stop living in self-protection so that we can live in like connection. That's like a huge component of what we do too, is just teaching kids, like kids are either in safety or they're in connection. And so many of the kids we see are just stuck in safety mode all the time, that our job is really just to train them how to get out of safety so that they can live in connection. Okay, any other questions before I jump to the next question on our little list here? Okay. Let's see. The next question on here said, what does the process of starting occupational therapy look like, and what does an evaluation consist of? I can start with this one. So to get referred for occupational therapy, there's a couple different ways you can access OT, and some of it depends on your insurance provider. So, in the state of Iowa, if you have private insurance like Blue Cross Blue Shield, United Healthcare, you can access OT without needing a physician referral. So it's called direct access. So you can just give us a call. We'll give you some paperwork to fill out and then get you scheduled for an OT evaluation. Um, if the child has or the patient has any sort of like government-based insurance like Iowa Total Care, any sort of Medicaid, Medicare, TRICARE, um, then we need a primary care physician to send us a referral. Usually that's not hard for us to get. It just requires that the child has been seen by their primary care. So they send us over a referral and then we get you scheduled. So there's some paperwork that parents fill out or caregivers fill out that includes a medical history for the patient. Takes us through like pregnancy, any sort of like birth trauma or any sort of early infancy challenges the child might have had, developmental history, and then just a little bit more about the child, like how they communicate, if they have any feeding issues or social challenges, just general descriptions of the child and the home environment. It really just helps us get like a whole picture of like what this child looks like outside of our time that we'll get to spend with you during the evaluation, so we don't have to ask you all those questions while you're with us. And then there's also a couple other forms we have parents fill out. So one of them is the sensory profile. So it goes through and asks caregivers to rank how children respond to different types of sensory inputs. So again, this helps us to see like how do children respond to different inputs within their environment, and we score that and see like where children fall kind of within a bell curve. Like, do they process information just like most other kids? Are they more sensory avoidant? Are they more sensory seeking? It helps us determine kind of where they fall on the sensory spectrum. And then the last piece of data that we kind of collect at that initial evaluation is a reflex checklist. So it is just a checklist parents fill out that has little sentences. You just check the mark if the child fits that description. So child falls out of their seat frequently, check. Child has trouble sleeping, check. Just go through the list. During that initial evaluation, it's 40 minutes. Part of that time is spent with a child and we're running through different assessments. So we're checking those primitive reflexes, we're checking different developmental skills, fine motor skills, visual skills, kind of just a general like, how does this child process information? What's their coordination look like? Do they know how to control their body? We're also within that kind of looking at like, how do they interact with us? How do they interact with mom and dad or other people within the space, direction following, things like that. And then the other portion of that is a parent or caregiver interview where we just have time to talk about like what's going on, what brought you to therapy, and what kinds of goals you guys have for the kiddos. So that's kind of the primary portion of the evaluation. Sometimes if we didn't feel like that covered what we needed it to, we might have some other forms to fill out, but that's generally how an evaluation would be run.
Maggie, were you going to ask a question? I feel like you had unmuted a second. Yeah.
I guess I was just trying to figure out like how do I know if my child needs help? I think he has trouble with proprioception kind of area. But
Sure.
like I said, like Rachael was saying, like should every day shouldn't be a battle, but then at the same time, homeschooling I heard is hard. So like,
Sure.
where is the line, you know?
Yeah, I think too, a lot of times it goes back to function, you know? So even when Rachel talks about what our evaluation looks like, you know, if we find some areas that seem to be deficient, we want to make sure that it also is an area where the family is noticing that the child is struggling. And, you know, even looking at proprioception. So, you know, proprioception impacts the child from a coordination standpoint because they might end up being a little clumsy, but it can also be a pretty big social skill and behavior issue, right? Because if this child um, doesn't know, you know, how much force he's using when he's playing with other kids or when he's throwing a ball at another child, then eventually that gets to be kind of annoying to their friend, right? Because now the
Right.
ball's always flying at my face or way past me. You know, so really kind of looking at that. I don't know. Is there more specific, um, you want to share anything more specific? Because we could maybe help you tease that out.
Yeah, you've actually shared some examples like, you know, tossing a ball or his siblings are the victims
Right.
oftentimes.
Yeah.
Yep.
He is kind of clumsy, and a lot of times he thinks that he's being playful, but he's using too much force for his siblings. He
Yep.
puts a lot of pressure when he's writing,
Mhm.
and um,
Yeah. Does he fall
yeah,
just for
things like
fun? Is he a
uh,
crasher?
he just falls all the time.
Yeah.
Okay.
Yeah. Well, and even Maggie, like I just think about like even if it doesn't feel like that, like if you have questions about like I don't know, I just don't know if like now's the time or like is it bad enough yet? I always fall back on too like the implications of like what is this doing for self-confidence too? Like if I'm constantly having to redirect like you're doing this again, you did it like you know
Yeah.
the kiddos don't love to have redirection constantly either. And I always think of it as like, how would it feel to be in a body that you aren't in control of, or like in the driver's seat of a vehicle that you don't have the steering wheel for, or you don't have the gas pedal and the brakes? Like, that's pretty uncomfortable. And so, like, as we work through development, I mean, I don't know how old your kiddo is, but the brain is never going to get more flexible. So the younger the child is, the more flexible their brain is and the more adaptable it is to change. So the younger the child is, I mean, this is within reason, right? A 2-year-old is going to be harder to work with just in general because it's harder to follow directions and set up activities, but it's never going to be easier to make change within the brain than like the younger they are.
Sure.
So there's kind of a sweet spot of like, we don't want to wait until they're 15, 16, 17 and now be like, they
Yeah.
still can't write and they still can't hold their body up in a chair for longer than 30 minutes at a time.
Yeah.
So not to urge you one way or the other, but I just think about it from that lens too sometimes of like, sometimes it's like, how do we just make this as efficient as possible? Because like we'll have families come in too sometimes where like we are, I don't know, I'll give an example of like, we're now 12 and we've been dealing with these challenges since we were 4, 5, 6. And now we need a plan of care that might be like a year and a half long because like progress is just going to be slower versus like if we addressed it at 4, 5, 6, it could have been a 3, 4 month. Like we work on it for a shorter window of time and we make a lot of progress in that window of time. Does that make sense?
Yeah, it makes sense. My son is 10.
Okay.
Okay.
Yeah.
Yeah. Well, and 10 is kind of when they start to recognize some of these things too, right? You know, they become a little more socially aware, like that maybe they're a little bit, you know, their friends are doing something, but they aren't quite able to do that. And so I think that self-esteem piece is can be pretty big around that age. So the other thing is, you know, our sessions are super fun. And so, I mean, that's one of the things that is it's a requirement. Like the child has to enjoy it and they have to have fun. And so, we find that kids are pretty willing and excited to come to occupational therapy sessions. And so that usually helps too. We never want a child to feel like there's something wrong with them or,
Yes,
why
it
do I
doesn't
have
feel
to
like
come
work.
here?
Right.
Yeah, exactly. So, I think that makes it easier too as a parent because you're not, necessarily having to drag them and kicking and
Right.
screaming and yeah, not wanting to do it. So, any other questions to piggyback back off of that, Maggie? Did that answer your question?
Um, I think so, yeah.
Okay.
Well, there was one question that we got that kind of, I think, piggybacks off of the evaluation question and kind of off of what we just talked about. One of the questions was like, what should I tell my kids to expect? Um, Elise, do you want to answer that or I can answer? Up to you.
Sure. Yeah, that's a question I get often, especially from moms of kids who maybe are a little bit older. And for kids who maybe have a little bit more apprehension about appointments, right? So I think the number one thing to always tell them is, you know, I've heard that it's really fun and that you're going to just be asked to do some fun, different things, and that it's going to be pretty easy. Assure them that there's not going to be any needles. It's not like a doctor appointment where, that can be kind of uncomfortable. And then, if they're wondering, well, why do I need to go? I think even just explaining it like, you know what? If your child plays sports, like let's say they play soccer, like, you know what, we're not going to just show up at games, you're going to have practice. And it's the practice time that's going to help with making things a little bit easier. And so helping them understand, you know what, we're going to learn some things that we can practice, that we can work on so that things are easier for you. A lot of times in my evaluations with kids will even ask them, if there was one thing that you wish could be easier or you could be better at, what would it be? And I love hearing the responses to that question because we want to make sure that we're not only fulfilling what the parent sees as being something that they want to work on, but also that the child has something that, is important and meaningful to him or her too. So,
Yeah, I often tell kids that, like, when we're going through our evaluation process, I tell them, like, I'm just looking to see how well our brain and body are working together because sometimes our brain and body get a little disconnected and that just makes things tricky for us. And a lot of times kids will come in and they'll tell us, like, oh, yeah, like, mom told me I got to come to the game doctor today. So they'll call it like the game doctor or something like that. But often for our older kiddos too, I'll describe our sessions as like we're going to get to do obstacle courses or scavenger hunts or
mhm.
different movement type activities that are just going to teach our brain and body how to work together. Some of these questions we kind of already answered, like if we need a referral from a doctor. Another one was if there's overlap between OT and more like psychotherapy, talk therapy, or play therapy. I can go ahead and talk through this one. Sorry if you can hear the elevator behind me. Um, so we see quite a few kiddos. I work in our Ames location, like I said, and we see quite a few kiddos that are seeing both like mental health counseling or therapy or play therapy and OT. And there is quite an overlap, I would say, between the two, especially when we're thinking about addressing like mental health or emotional regulation skills. They do differ in like the way that we approach that. So where OT, if we're going back to that pyramid, like Elise said, OT is working more on that like sensory based strategies or those reflex based strategies. Whereas like talk therapy is going to be more at that like cognitive behavioral level. So that's going to be higher on that pyramid. That's more of a top down approach, whereas OT is going to be more of that bottom up. Um, for kiddos that are in play therapy, that's just a different modality entirely. So that's a little bit more like trauma based and trauma informed. Like, how do we teach them to play out their trauma? And quite honestly, what I think the best intervention or like the best kind of mix of the two is when kids are engaged in both, especially if they have a history of trauma. So a lot of times we'll have kids that are seeing multiple therapists or multiple different types of therapy at the same time. So it's not like one is better for X, Y, or Z and one's better for A, B, and C. The two overlap, and I think the best combination is like two in tandem. See.
I have a question.
Okay, got a
Okay,
question?
so I have
Yep.
I have a cousin, and he has a disability, and the things like he has trouble pooping, and his potty time was kind of delayed. So it's like, how can I advise his parents of like going to potty time without him feeling fear?
Mm-hmm.
That's when he comes to my place, it's like he's good, he's confident of doing it. But in his own environment, it's like he sees potty time as like scared, you know what I mean? So how can I
Yeah.
advise?
I would say like one strategy that I would recommend is like engaging in so like if the bathroom in and of itself is stressful for him, like doing other activities in the bathroom itself that don't involve going to the bathroom. So let's say he really loves puzzles and puzzles are really relaxing for us. Maybe we start associating like, okay, instead of going every time we go to the bathroom, we're going to the bathroom to poop. We're going to actually go to the bathroom and we're just going to sit outside the bathroom and do a puzzle today. We're not going to go poop. We're just going to do something that we actually really enjoy near the bathroom. So, doing things to create a different association with the bathroom, or even like we're going to go do that inside the bathroom, kind of getting us closer and closer to that environment that feels stressful. So not necessarily starting with like, we're going to put you on the toilet and you're going to do a puzzle,
Mm-hmm.
but maybe starting close to and then working our way closer and closer until he's kind of got a little bit more of a positive association would be one strategy.
Yeah. And it sounds like, there's physiologically not anything going on, which, that's the thing that I would always rule in or rule out first. But if he's able to, go to the bathroom one place but not in another, you'd also want to look then, so is he holding, which that can then lead to constipation, which can, lead to pelvic floor issues. And so it is an important thing to work on. We also look at interoception when we look at toileting. So interoception is our internal sensory system, which gives us cues of, so that we know that we have to go to the bathroom. And sometimes kids aren't getting those cues. And so it doesn't sound like that's the situation here, but just there's a lot of different things to consider when looking at why a child is maybe going to the bathroom one place and they won't go another place. We get it a lot where maybe they go at home, but they won't go at school. And so even then looking like, well, how's your bathroom set up at home? Is it such that he can put his feet on on a step stool or can reach the floor, but in a public place they can't, so then they don't feel grounded and safe sitting on the toilet, so yeah, just lots of different considerations. But I think, yeah, like Rachael said, if it seems like those things aren't necessarily to play, I love that idea of, yeah, making the bathroom a non-scary place and no expectations around it at first. So any other questions? Okay. Rachael, did we answer all of the ones that had been sent to us?
There was one more.
Okay.
The last one was how long is a plan of care? I can answer this one. It depends. There's not a set answer to this question. It really depends on the family or the situation or the client. So there isn't a set, like we see a client for X number of visits and then we're done. Typically speaking, we'll start with once a week for pediatric patients. And a lot of times we'll see them for, I don't know, it depends on the patient, but we'll start with once a week. And as we feel like we're progressing, we'll drop down to every other week, then maybe once a month. So it's never, we're not usually a like, okay, we go from every week to cold turkey, like you're done, you've graduated, see you later. It's kind of a progression. With that being said, too, when we discharge kiddos from therapy, we also have kind of a follow-up process from there. So we typically will reach out at 30 or 60 days and then again at 6 months and just check in and make sure that things are still going well so that you guys have an opportunity to just check in with us and ask any questions that might be lingering or if things have come up, you have a touch base point as well. But it depends.
Yeah. And I think too, to add to that, like factors that cause it to depend on, the child and the family are how consistent is the home program being completed. So all of our kids have home programs because the most change happens when you're doing things outside of your once a week 40-minute appointment. And so I'd say there's a definite correlation to being consistent with home program and being able to graduate a little bit quicker. So.
Did you say it also depends when it comes to how long each session will be, like each time we come in?
No, those are always 40 minutes.
40 minutes.
Pretty typically. Yeah. There's, maybe a case here or there, but 40 minutes is the typical appointment length.
Okay.
Yep.
Any other questions?
You were saying we would need a referral from the primary doctor.
So that, depends on your insurance. So private insurance does not typically require a referral, whereas the state-based insurances do. And we are always happy to check on that for you also. So like if you would call and make an appointment, we can, double check and make sure that you don't need a referral, but
we are
some
on the
homes do.
state
Yep.
insurance.
Yeah. Yep.
So how do we get started, so to speak?
Mm-hmm. So I would say the best thing would be, we can help you find which do you know like which clinic is going to be closest for you?
I think the Pella one. We're by Kelowna.
Okay. Yep. So either Pella or Oskaloosa, which I'm in both of those locations. So, and have a fair amount of clients who come from that neck of the woods. So, I would say, there'll be a couple different things that we want to get started, but probably calling into our clinic first, just to be able to get the paperwork, because we want to get that sent to you right away so that you can fill that out and get it back to us. And in that time, then you can also work on, reaching out to, do you have a family physician?
Yes.
Yep. So I would reach out to your family physician. Some of them, require you to come in, but some of them, if you've just recently seen them, you can just say, hey, we would love to try occupational therapy. We have a clinic that we're planning on going to, and we need a referral. All that the referral needs to say is occupational therapy, evaluate and treat. Doesn't have to really even have like a diagnosis on it. And then once we have that, then we will do the evaluation. And because we have the referral from your physician, the physician will also get like the evaluation and plan of care, and then they'll sign off on that as well. So, yeah.
Okay.
Yep. If you, We have an 800 number. It's on our website. And our website is kineticedgept.com. But if you wanted to just call like our Oskaloosa clinic or our Pella clinic, I could give you those numbers.
Okay.
Would you like that?
No, I sorry.
Yeah,
I just
that's
saw the
okay.
website. I saw it.
Yeah.
I found the number.
Our Pella clinic number is 641-621-0230. And our care coordinators have access to the schedules at all of our locations. So if you called and talked to Molly or Laura, and like if you want a specific day or time, or first available, they would be able to look at both Pella and Oskaloosa and give you a wide variety of options. So
Okay.
yep. Great. All right. I think too, like just always know that